Um, so again, today we're going to talk about preparation and integration in regards to ketamine treatment for depression. And our objectives today, I want to introduce ketamine as a treatment for depression and speak about the model of care that Ember Health practices. I want to discuss how ketamine works for depression and also why therapy enhances positive outcomes of care. I want to share a little bit about our patients' in-office experience at Ember Health and how therapists can help our patients prepare for treatment and integrate what surfaces during the treatments. And I also want to explore how Ember Health can partner most effectively with you in our patients' long-term care. This talk will be about 20 to 25 minutes, and then we'll have some time for Q&A and discussion. If you have any questions during the presentation, feel free to raise a hand or send a message in the chat, especially if it's contextually specific. And then I'm also happy to answer questions at the end as well. So, ketamine for depression. As you all know very well, depression is a large and pervasive problem. And traditional antidepressant medications have had variable results and have significant side effect profiles. Ketamine for depression has been an exciting space due to much higher efficacy rates, an excellent safety profile, and minimal side effects. As you see in the slide, traditional serotonergic antidepressants have efficacy rates in something like the 30 to 50% range, take a long time to do anything, and often have unwanted side effects. Whereas with ketamine, we're talking an efficacy rate of 75%. 75% of patients with significant improvement in their depressive symptoms after a series of ketamine infusions. And that is not inflated data. That comes from a large-scale clinical trials, and we've replicated that data internally, and we see even higher efficacy rates, closer to 82%. Also, ketamine works essentially immediately. Many patients report improvement in their depressive symptoms 2 to 3 hours after an infusion, hours. And we see in the vast majority of patients, we see their antidepressant effects come forward within 2 weeks of completing their initial infusion series. So from the day they start care with us, within a month, 75% of patients are feeling much better. The first clinical trial of intravenous ketamine for treatment-resistant depression was in 2000 by what is now the Interventional Psychiatry Group at Yale. And since then, there's been a growing interest in ketamine as a treatment for depression internationally. Last year alone, 673 papers were published in this area. I want to emphasize that this is no longer an experimental treatment. This is mainstream. The data is well established. There's a massive body of literature on intravenous ketamine as a treatment for depression with data from thousands of patients. And there continues to be, as you can see in this slide, an ever-growing body of literature that's helping us to answer questions about how to maximize the benefits of ketamine for depression. Ember Health was created to provide safe, effective ketamine therapy for people seeking relief from depression, and our vision takes a systems-level perspective. We are committed to helping set the gold standard of care for ketamine for depression. And we were founded on 3 mutually reinforcing concepts. We are evidence-based. Everything we do is based on the best evidence available. And this gives us credibility to our patients and our collaborating provider partners as well. And we contribute to the field academically. We partner with academic institutions to share data and advance knowledge about ketamine for depression globally. We also are patient-centered. We believe patient experience matters. We try to think of every detail to ensure our patients have the best experience possible, and we believe that this leads to the best clinical outcomes. And we also cultivate an ecosystem of care. We see ourselves as one part of a patient's healthcare team, and we know that well-coordinated care leads to the best outcomes for our patients. So a significant part of my role as a clinical director is actually communicating with mental health providers like yourselves to optimize patients' care plans, which we'll talk about more in depth later in this talk. So how does ketamine work? So from research that does exist, we know that there are three distinct benefits from treatment with ketamine. There are neurobiological mechanisms of action, there is an experiential mechanism, and there are also adaptive mechanisms of action that play important roles here. Um, as I mentioned earlier, the first clinical trial of ketamine for treatment-resistant depression was in the year 2000. Initially, patients were given a single infusion of IV ketamine over 40 minutes, and later studies found that multiple infusions in a row over about a 2-week period were even more helpful. This early success led to many studies looking deeply at the mechanisms of action of ketamine, meaning how ketamine actually works to treat depression. I'm going to get into this a little bit more in depth in all three, in terms of all three mechanisms. So first, I'm going to talk about the neurobiological mechanisms of action with ketamine. So patients with depression have dysfunctional glutamatergic neurotransmission. So they have dysfunctional excitatory neurotransmission, especially in the limbic system or the emotional reward system. This is in large part why we see anhedonia so commonly in patients with depression. Sophisticated neuroimaging studies of depressed patients actually show volume loss, anatomic shrinkage in their limbic system, and they also show decreased connectivity between cognitive control centers like the prefrontal cortex and the anatomic components of the limbic system like the hippocampus. So, in other words, depressed patients often have small, dysfunctional emotion reward systems that don't connect normally with their cognitive control centers. What is especially fascinating here is that these changes have been found reversible in subsequent studies of ketamine in depressed patients. Why is that? So, ketamine stimulates neuronal regrowth, regrowing neurons, and synaptogenesis, or making new connections in the limbic system. And it also increases connectedness throughout brain regions, between different brain regions. So we see normalization of these connections throughout the brain and normalization of neural signaling in the limbic system that are probably responsible for the major part of ketamine's antidepressant effects. What I want you to remember from this is that ketamine essentially resets the emotional reward system because it allows cells to regrow there and it allows synapses or connections to reform. There are multiple other mechanisms of action of ketamine that have been elucidated, and there's probably a synergistic effect here. There was one particularly interesting paper that came out recently in the Nature journal, Nature meaning one of the highest impact journals that exists, just sort of to go back to my point that this is not an experimental treatment. And this publication highlighted an increase in circulating endorphins that also seems to play a major role in the antidepressant effects of the ketamine. So resetting the emotional reward system and synergy with other biologic mechanisms. Now let's talk about the experiential mechanisms. These are often referred to as mystic or psychological experiences that occur in the infusion. As we all know, depression is much more than just neurobiologic and chemical changes. It involves the core of who we are, what we believe, and how we interact with the world around us. Patients with depression, as you know, they feel hopeless, they can be isolated, they can be highly self-critical. The experience of the ketamine infusion, patients experience an altered state of consciousness. And this altered state introduces patients to a different way of thinking that disrupts depressive thought patterns and behaviors. During the infusion, they may experience a totally new way of thinking. They may have a change in perspective or gain new perspectives that can be quite powerful. And they can experience even a freedom from concerns of the past, freedom from guilt and anxiety. And this opens all kinds of possibilities for patients who are, this opens up all different kinds of possibilities for patients to change their core psychological beliefs that are core psychological components of their depression. Additionally, fruitful psychological content can come up in the infusions that can be very useful to explore in psychotherapy. I think this is particularly the case for our patients with a history of trauma. And there's some suggestion even in the literature that interaction with these prior traumatic memories while in altered states may allow reprocessing of these memories and improve trauma-related symptoms. So changes in perspective from the experience and fruitful psychological content to bring into therapy, reprocessing of memories. Some studies even indicate that mystical experiences in the infusion may correlate with improved therapeutic outcomes. That being said, the majority of data indicates actually that the neurobiological antidepressant effects of ketamine will remain intact regardless of the depth of the altered state. The reason I mention this is that I think it's important to emphasize to patients that they don't need to put pressure on themselves about having any specific type of experience. The ketamine, the medication, is going to exert its biological antidepressant effects regardless of the psychological content that is experienced during the infusion. When the psychological content provides an added benefit, that's wonderful. That's a cherry on top, so to speak. Now, I want to talk a little bit about some adaptive mechanisms of ketamine's mechanism of action. So we often talk about the neuroplastic effects of ketamine. Ketamine has been referred to in the literature as a neuroplastogen and a psychoplastogen. Meaning, I think this was put best in a recent paper in Frontiers of Psychiatry. This is a fast-acting compound with the ability to precipitate structural and functional reorganization of neural circuits that facilitate positive and sustained behavioral change. So what does that essentially mean? What it means is essentially puts the brain in a juvenile-like state, which improves patients' ability to learn new things and adapt to new habits. And you can probably imagine how this can be helpful for depressed patients. Our patients find that the ketamine, the neuroplastic window after ketamine, assists them in adopting healthful habits such as exercise, improved eating habits, sleep hygiene, and even work on substance use. So the neuroplastic window lasts for 2 to 3 weeks after a ketamine infusion, and during this time, patients may find it easier to develop new habits, and it's something that can be capitalized on in psychotherapy, particularly as many of these healthful habits are known to improve depressive symptoms as well. So to kind of summarize, I know I spoke about a lot of things on this slide, but to kind of summarize, biological mechanism of action, resetting the emotional reward center is the main mechanism. Experiential mechanisms involving changes in perspective, fruitful psychological content to bring into therapy. And then we talk about a neuroplastic mechanism involving adaptive learning and patients having an easier time developing healthful habits, which coincidentally also can help them with their depression as well. So I want to talk now a little bit about the combination of IV ketamine and therapy. Studies have shown that that ketamine treatment is more effective when it is paired with psychotherapy, which is one of many reasons why we take a partnership-based approach to our care. And there's a growing body of literature on this, a growing body of literature on using psychotherapy to optimize patient outcomes with ketamine. I want to present one paper which I think is particularly interesting and helpful in how we think about the synergy between ketamine and psychotherapy. So this is a nice study from 2021 from the Interventional Psychiatry Group at Yale. 41 patients received ketamine infusions for treatment-resistant depression, of whom 28 had a treatment response. And of those 28 patients, about half were randomized to receiving CBT alongside their ketamine treatment, and the other had treatment as usual. Patients in the CBT group were treated with twice-weekly CBT for 2 weeks. And then they were treated with weekly CBT for an additional 12 weeks. And then the other group, the TAU or treatment as usual group, just received treatment as usual without CBT. So what did they find? What they found is that patients in the CBT group had a more sustained antidepressant response after ketamine infusions than those who did not. And this response was not only statistically significant, but was long lasting. This study is important because it indicates that CBT may help sustain the antidepressant effects of ketamine. And when you look at this slide, the blue line here is the treatment as usual group, and the orange line is the cognitive behavioral therapy group. And you'll notice that depression severity reduced long after ketamine treatment was finished, and patients had a much more robust outcome when their treatment was paired with CBT. CBT and ketamine, the benefits may combine synergistically in 2 ways. We know that ketamine enhances neuroplasticity, and CBT may help to stabilize these synaptic connections to improve long-term outcomes. Another way of saying this is that the neuroplastic window from ketamine allows for an enhanced ability of CBT to work. Additionally, ketamine may resolve depression-related cognitive distortion. That kind of goes back to that experiential mechanism with changes in perspectives. And CBT may act to sustain these cognitive changes, thus maintaining therapeutic effects. I suspect that these results will be replicated in studies with other forms of psychotherapy as well. And I don't personally believe that CBT is necessarily any better than other modalities combined with ketamine. But I highlight this study to show objective evidence for a synergy between therapy and ketamine, and to highlight how important this pairing is, and why we find it so important to collaborate with you for our patients. So back to the mechanisms, we talk about ketamine having multiple complementary benefits. When patients feel better biologically, they find it easier to motivate around life tasks and engage in difficult conversations and topics. The experiential nature of the infusion provides an opportunity to work through psychologically fruitful content that comes up. And the neuroplastic window provides an opportunity to identify helpful life habits and desired behavioral change, and then to capitalize on the neuroplastic window in adopting these helpful habits. Anecdotally, I can tell you many patients tell me that they have had positive life changes related to their ketamine therapy around things like eating habits, sleeping patterns, exercise, and also smoking, alcohol use, and other substance use. So, some people talk about set and setting, which is a phrase that was coined as part of psychedelic assisted psychotherapy. And while ketamine is not technically a classical psychedelic, it does have a similar type of altered state. Here at Ember, we have created a safe and supportive setting for care, and we strive to think of and optimize every detail to make each patient's experience as positive and meaningful as possible. So starting with the environment, we have soft lighting, we have a beautiful aesthetic. We try to make this feel like they're at home in a warm living room. We also pay a lot of attention to our tone, being open, non-judgmental, warm. And then we also craft a supportive ritual around the ketamine treatment. This ritual involves intention setting. And just as a reminder, intention setting is essentially a commitment to a positive state of mind or state of being that helps bring patients into an optimal state of mind to experience the altered state. So some examples might be to be kinder to myself, to be accepting of who I am, to embrace a positive outlook, or to feel more connected with the world around me. And I do have many patients that are a little bit resistant to this at first, but I really believe that this is important, and patients find they have a much more positive experience when they take the time to develop a supportive intention. We also use music during the sessions, and we have noise canceling headphones with curated music that works well with and is supportive for patients during the infusion experience. And it's interesting, the reason we do this is that in addition to subjective reports from patients that this makes an impact, this is actually evidence-based. A recent study from a group in Montreal looked at using either noise canceling headphones with no music at all, or patient-selected music during the infusion, and they actually found much improved vital signs during the infusion in patients who were listening to music. So meaning better blood pressure, better heart rate, things like that. To me, what that indicates is that this translates as data that music helps make the infusion experience more positive and less stressful. We also, in addition to the music and attention setting, we also have curated aromatherapy and teas, which are designed to correspond to core mood states. And my personal favorite of our aromatherapies is called Calming, and it actually has lavender in it. Which has been shown to be an effective anxiolytic. This is evidence-based stuff here, and it really makes a difference. After the infusions, we hold the space with patients. This is not psychotherapy. I'm an emergency doctor, as a reminder, but we do listen and support patients, and we help our patients to identify things that they should bring into their therapy sessions to process and integrate further. Um, we encourage patients to journal after the infusion, and we have beautiful reflection and recovery areas in our offices for patients to sit and reflect and journal immediately after their infusion. And this is particularly helpful for patients in identifying and recording psychological content that can be brought into therapy later. Just briefly about the in-office experience. So patients book 90-minute infusion appointments. They come into the office, they'll fill out a PHQ-9 mood survey, which is the metric we use to track depressive symptoms, in addition to subjective reports. After they fill out the survey, we'll bring them into the infusion suite, we'll establish an IV, and then we'll craft the ritual around the ketamine together with the intention setting, music selection, and aromatherapy selection. And then generally we'll do a breathing exercise and smoothly transition into the ketamine infusion. The infusion itself lasts for 40 minutes, but the altered state lasts for about 50 minutes as the plasma levels of the ketamine decrease as it's metabolized. And then patients, we welcome them back after the experience, and we support them in processing their experience. And then after that, we medically and psychologically clear them that it's safe for them to go home. And we invite them to our reflection and recovery area after. Patients do not need accompaniment to the appointments. They can go home by subway or taxi, what have you. The only thing is they cannot drive for 6 hours after the infusion. So I want to talk a little bit about what the experience is. And I'll tell you, this quote from Dr. Sherry Ann Muscat, who's an academic psychologist from Alberta, wrote, I think it really sums it up well. This is a meaningful, transcendent experience of oneness, connectivity, hope, and happiness. So ketamine can have both physical and psychological effects. With the doses we use in the infusions, patients are conscious, they are able to speak, but they do enter an altered state. Physically, some patients will describe a feeling of floating or a sensation of movement at times during the infusion. They may also experience very vivid imagery and or have other sensory experiences, such as a change to the perception of sound. Psychologically, as you can imagine, the experience can be quite profound. Patients often describe thoughts flowing like a river. And they talk about the infusion being perspective granting, which I alluded to previously when we talked about mechanism of action. They also can find the experience to be very, very meditative and peaceful. Others describe a certain connectedness with the world that they haven't experienced before. This connectedness can be just with the world at large, but also patients will find that they feel connected to people from their past, loved ones. They may think about connections with friends or other individuals that they haven't thought of for a long time. The experience can also be quite reflective and philosophical. Patients will talk about new ideas that they thought of during the infusion, which really impact the way they think about the world around them. And other patients describe it as kind of a dreamlike state. Some people find the infusions very pleasant, and for some, it's hard work. Sometimes prior traumatic memories can come up, which can be challenging to work through. But I'd say globally, 90% of infusions are described by patients as positive, 10% are difficult. And the experience may vary significantly from infusion to infusion. In the setting of patients having a difficult infusion, generally all we need to do is reassure the patient that they're safe, that they're here at Ember Health. And that is generally all we need to do to kind of help bring the patient back to a more comfortable place. And then we also communicate with patients, the rest of their mental health team when that happens, to make sure the patient is feeling supported globally. I want to reemphasize here what I mentioned earlier, that the psychological content does not change the neurobiologic efficacy of ketamine as an antidepressant. The pressure that some patients put on themselves to feel certain things or have certain experiences actually, in my opinion, is counterproductive and can lead to them having a more negative experience and not having the experience they want. And so I try to put as little pressure on it as possible and let them just accept what comes up. A difficult session does not mean the medication will work less well. The same goes for a more positive or less challenging experience, or even an experience with less depth where patients feel that they're not quite as altered as they may have been some other time. That does not mean it's not working. Okay, so now I want to talk a little bit about some more practical things about preparing for ketamine treatments, and how you can help your patients prepare emotionally and logistically to make the most of their treatments. So this content all comes directly from materials that we have prepared for patients. Our website is really well done and has a lot of great resources there. We spoke earlier a little bit about this concept of set and setting from the psychedelic literature. And it can be really helpful for patients to prepare emotionally for sessions. We want to minimize stress to make this as positive an infusion experience as possible. And patients also find it helpful to reflect on their goals for ketamine treatment and explore intentions with their therapist. We also want to consider and manage expectations. So some questions that can be really helpful to explore with your patients may be, what can I do to minimize stress leading into care? What healthful behaviors do I want to commit to leading up to my infusions? What are my goals for this treatment? How will I manage my expectations if I do not respond as I expect to treat? And one small point here, we expect 75% of patients to respond. That response may happen anytime from 2 to 3 hours after the first infusion to 4 weeks later, when they're finished, after 2 weeks after they finish their initial series with us. And so managing expectations is really important. Another thing that can be extremely helpful for patients is to discuss intention setting. What is an intention or commitment to a pattern of thinking and way of being that I can make to my care? And I will explore that with the patients as well. But some patients really like to explore this in therapy, find it really helpful to come in to their infusion having something that they've already set with their therapist. Preparing logistically, it sounds kind of like a simple thing, but it actually really makes a big difference, and it can reduce stress levels around the treatment and make the experience more positive. So questions around establishing a plan for getting safely to and from their appointments, ensuring ample time and space for reflection after the session, and making sure they're scheduling time with you before and after treatment for preparation and integration. Let's talk about therapy sessions after ketamine infusions. So, integration is helping to process what came up during an infusion. And essentially, it involves just being a good therapist. We'll talk more in a moment about specific questions that can be particularly helpful to explore. But I want to talk a little bit about some of the logistics here. So, in terms of timing of therapy sessions around ketamine, so logistically, we actually find that patients prefer therapy to occur sometime between 24 and 72 hours after their infusions. The reason that we do not recommend therapy alongside the infusion is that this is a very inner space type of journey. Patients will not always have coherent thoughts that they can express during the infusion itself. And at the doses we use, this is a very immersive experience, and talking takes patients out of this experience. Immediately after the session, immediately post-infusion, patients will also have difficulty verbalizing feelings. Their word center's kind of off kilter, and they often feel quite tired, and they have a desire to recover and reflect internally before engaging outwardly. Some patients do like to have therapy the same day, like a few hours after the infusion, when the psychological content is freshest in their mind. But others feel too tired for this, and the integration can occur later and be even more productive at that time. And this goes back to how we encourage patients to journal, to record psychological content that comes up so that they can have good recall of it when they bring it into their therapy. So let's talk about some questions that can be explored and can be helpful to explore during integration. So I like to think about integration in three ways, which coincide coincidentally with the mechanisms by which ketamine works. So we spoke about Biologic mechanisms, resetting that emotional reward center. We talked about the experience itself and the psychological content that comes up and how this can be perspective granting. And then we also talked about a neuroplastic window and adaptive learning. So to start with, the biology. So we want to help patients focus on what has changed with questions like, have you noticed anything that feels different from before? We want to look at interpersonal shifts. Have there been changes in how the patient engages with others? Have family or friends noticed a change? And we want to discuss cognitive evolutions. Have you noticed any changes to your thought patterns and inner dialogue? Um, we also want to consider what is unchanged. What has stayed the same that you may have expected to shift? How does that make you feel? This may also identify things that you need to work that would be helpful to work on more deeply in therapy, that things are not being fixed by the ketamine. Integrating experientially. So we want to reflect with curiosity. How would you describe your sessions? How do they make you feel? Is there anything you're noticing as you reflect further? And focusing on what felt important, what they journaled about that they brought to you to discuss, what topics or ideas have felt particularly important and recurring, how do they relate to what we've explored before, if at all, and identifying enduring themes. Are there themes that you'd like to continue reflecting on from these experiences? What do you want to take from them moving forward? And then I want to also talk about capitalizing that neuroplastic window during integration. And I would advise considering this after every infusion, and how adaptive learning can lead to treatment effects lasting longer. So starting out with this, helping to establish helpful practices. I like patients to identify practices that they want to adopt to extend the benefits of ketamine treatment. So talking with patients, is it maybe they need to spend more time doing cardiovascular exercise? Maybe it's that they need to drink less alcohol, and so on and so forth. We want to think about barriers. What do you anticipate hindering your success with ketamine treatments over time? What are some things that ketamine won't be able to change? So, for example, when we talk about long-term care, which I'm going to talk a little bit more about in a moment, we have two different types of care plans. One is a symptom-driven approach, which requires patients to actively fill out mood surveys so that we can see when their depression worsens and bring them in for a booster. That might be something to identify early, that they're not good at doing that, or they need to focus in on doing that so that we can do a better job for them in helping to keep their depression under control over time. We want to define what success means for the patient. What would it look like in the long term if ketamine treatment is successful for you? What are your goals of this treatment? And we want to articulate a plan. What might be indications that your depression is returning and you need to come back in to Ember for a booster? And how will you engage with your care team when that happens? Are you going to send an email to Dr. Adams? Or are you going to call the office and schedule? Am I, the therapist, going to communicate with Ember? All really helpful things to try to bring all of this together: the biology, the experience, and the neuroplastic window, the adaptive learning. Some overall clinical guidelines. Again, this is stuff that you all are natural. You're all natural at doing. You want to allow patients to share at their own pace, support a stance of curiosity, and really treat the ketamine sessions and the material that comes up just like you would any other important experience in a patient's life. Provide positive reinforcement when appropriate. Reflect back on differences you may be noticing in mood, temperament, philosophical interests, etc. And also, and this is a really important one, reminding patients that negative emotions don't inherently mean that treatment has failed. Ketamine treats depression, but what it does not do is prevent patients from appropriately feeling sad when something bad happens. If they have a bad day, they're still going to feel bad. And I think that's an important thing to remind patients of, so that they have an appropriate perspective on what has changed, what can change, and what cannot change. So let's talk briefly about what long-term care looks like. So ketamine is not a cure for depression. We often get patients' depression to fully remit with a series of infusions, but unfortunately, depression's biology is such that it often recurs cyclically. So we see ketamine as a long-term intermittent treatment, um, treating depression as it comes up. And we count on you to help us and the patient gain a sense of when it's time to come back in for an infusion. This collaboration and ongoing bidirectional communication about our shared patients is critical for optimizing outcomes and determining ongoing care plan, which is why we emphasize our collaborative relationship so much. And we really value and lean on your continued partnership. Just briefly, there's two different types of care plans that patients can elect to use if they have a good response to the initial foundational series of 4 infusions. One is this symptom-driven approach where they will fill out a PHQ-9 survey, or we will ask them and hope that they will fill out a PHQ-9 survey every 2 weeks so that we can track their mood and intervene appropriately if their depression worsens. The way this would look like is they'll finish their foundation series, and then whenever their depression starts to return, we'd recommend they come in for an infusion. That can happen anytime between 2 weeks and 6 months after that infusion. And I'd say the average amount of time that patients end up coming in is something like once a month or once every 6 weeks. So that is the symptom-driven approach. And that works well for patients who are able to communicate their feelings and are willing to fill out the PHQ-9 surveys. The other approach is a pre-scheduled maintenance plan. And what that involves is patients will start by scheduling an infusion something like once a month or once every 3 weeks, depending on how they responded to the initial foundational series. And our goal over time will be to figure out what their depressive cycle is. So we'll start them out at once a month. If they start getting depressed again at 3 weeks, then we'll shorten their pre-scheduled cadence of 3 weeks. If they do well at 1 month, after a few months, we'll then spread them out to 5 weeks, then 6, so on and so forth. Our goal being to bring them in as infrequently as possible to maintain euthymia. So I wanted to thank you all for being here. I have my email address on this slide, and I'm happy to answer questions at any time. And I want to encourage you to please use me as a resource if any questions come up about ketamine. And also, I'm happy to talk anytime if you're considering whether a particular patient would be a candidate for ketamine treatment. And now I want to take time to answer any questions you have. And Mia, feel free to stop the recording.